Dear friends, dear colleague, welcome back to the Essential of Digital Dentistry. Welcome back to the Mangano Digital Academy. Let's talk about the application, the clinical application of digital dentistry in surgery. Once again, so in the last video we have talked about the custom-made CAD/CAM scaffold for bone regeneration in the case of only graft with customized, personalized, tailored scaffold and graft for regeneration. We'll talk about this also in this video, and I show you one surgical case, very, effective, fast and simple, just to give an idea how the whole procedure works. And before to do that, we need to talk about digital dentistry a little bit in general. As I mentioned thousands of times before, we have a scan phase for the data acquisition when we go from the real to the virtual. This is possible thanks to computer tomography, radiologists, but also structural light, so intraoral and face scanner, and also digital condylography for the movement of the jaw in the space. Then we have collected all this data, we have our virtual patient, the virtualization of our patient, and we can go through our plan using different kinds of software for guided surgery, software for orthodontics, software for prosto. And after we have planned everything, we can go straight to the making or the shaping phase. So production from virtual to real, thanks to milling unit, 3D printer, SLS, SLM machine. And after that we have the clinical application. So these are the basically the 4 steps digital dentistry is based off. And let's talk a little bit about custom-made CAD/CAM scaffold for Alveolar ridge augmentation. As I mentioned in the previous video, we are going to publish hopefully this interesting retrospective clinical study with 3 years of follow-up for the regeneration of small horizontal and vertical ridge defects in the mandible and the maxilla with custom-made CAD/CAM scaffold. These scaffolds are customized and they are made in hydroxyapatite beta-3 calcium phosphate, so they are entirely synthetic. And this is a case, and I show you exactly the straightforward the protocol, the surgical protocol. This is the preoperative clinical picture. As you can see, if we look at the frontal, we don't see the defect, but we can imagine there's a concavity there, and if we watch occlusally, then the concavity is clearly evident. It's a problem from the aesthetic point of view, so we need to regenerate bone, and there are thousands of methods to do it in this area. We can use guided bone regeneration with membrane, we can use a mesh for a titanium mesh for once again a guided bone regeneration. In this case we opted for a non-lay graft customized through this procedure. As you can see, the combined computer tomography is the first step. We need to acquire the anatomy of the patient, the anatomy of the bone, then the 3D reconstruction, and into specific software we can start to design the computer-assisted design, computer-assisted manufacturing scaffold. So first phase is the data acquisition and the second phase is the planning. We can already plan the scaffold according to the soft tissue and the hard tissue anatomy, obviously. We can prepare the hole for the fixation screw, we can study how to make it better. We can basically control everything, also thanks to the modern software like ReLU or DianioCAD for the artificial intelligence. This software helps us to superimpose all data automatically and most of all to segment the bone automatically. It works very well. This is the material used in this case. The material is called Rigenera 3D. It's a proprietary material provided by Biotec Btk, an Italian company located in Due Ville, close to Vicenza, very highly technological company. And this is the workflow for these biomaterials that are engineered and custom made specifically for the digital workflow. So there's a data acquisition phase. The dentist acquires the data of the patient through combined computer tomography, and then the dentist can send all data to the company. The company has a very valid service. And in this service, basically the engineer and the biologist, they design the scaffold using different software, and then they prepare the scaffold for milling, and they mill the scaffold in a controlled way, in a controlled environment, in a wide chamber, using different milling unit like this milling unit by Roland, DWX52, and everything is of course controlled, and we can obtain the scaffold. The material used in this case is an hydroxyapatite and beta-3 calcium phosphate. Combined together, we can have different combinations, 70-30, 70% beta-3 calcium phosphate, 30% hydroxyapatite, or eventually 60-40. In this case, we are talking about a proprietary material developed inside this company that work very well for this specific application. We can see the different phases of preparation of the scaffold before the sterilization, and then the packaging, and then the scaffold is sent to the dentist. Straightforward, this protocol goes to the surgery, goes to the intervention. So this is very important. The dentist not only receive the scaffold, but receive also a replica of the scaffold that is extremely useful, first to test the adaptation of the scaffold onto the bone anatomy of the patient. Second, to handle the soft tissues well. We know very well that we have to find, after all, we have to make a tension-free suture in order to have a success in this procedure, because if we have tension in the suture, there's a huge risk of dehiscence and then infection and failure of the scaffold. So we can play with the soft tissues very well thanks to this replica. The replica is very useful for this reason, and most of all the replica is very useful for preparing basically the hole for the fixation screw. So this is not the replica, this is the final material. As you can see, a porous material with the fixation hole there, but as I told you, this is the flap opened, the big concavity. As you can see, definitely we need to place something here, otherwise the results will be aesthetically not satisfactory and there's a risk for the implant. So we need a scaffold here, we need some kind of bone regeneration. We opted for a non-lay scaffold. We use this replica of the scaffold to check the adaptation that is perfect, and also to prepare the hole for the fixation screw. That is key, because fixation is key if we want to have bone regeneration, as well as angiogenesis. So the perfusion of the scaffold is also key. We need blood to go into the porosity of the scaffold in order to let the scaffold integrate along 6 and 8 months. As you can see, this is a very nice replica because it can help us to handle the soft tissue. It can help us to prepare also with specific drills and with specific fixation screw the bed for the fixation screw that we will use with the actual hydroxyapatite beta-3 calcium phosphate synthetic CAD/CAM scaffold that is here placed in position, screwed in, and completely perfused by blood. Angiogenesis is the fundamental key prerequisite for the osteogenesis. So without angiogenesis, we cannot pretend to have osteogenesis. So the scaffold must be entirely perfused by bone, and if possible, we can make some cortical hole to enhance bleeding in order to have a better results. What I want to say, what I want to stress here is that from the anesthesia to the bone graft to suture, it took only 25 minutes to make this surgery. So it is very fast, it is very simple, it is very straightforward, it takes very little. There's a perfect adaptation, so best adaptation, best result for the surgery, because we don't have any risk of failure because of lack of adaptation, movement. We can fixate the scaffold very well. The scaffold is full of blood. There's a huge intimate contact between the surface of the scaffold and the residual bone. That is perfect. And also the whole workflow let us to avoid to waste time trying to adapt the scaffold and to handle the scaffold that can be contaminated. So there's a risk of infection with conventional analog procedure. With this digital procedure, we can really be fast, effective, and extremely, satisfied after all from the surgical point of view, and the patient is also satisfied because the surgery doesn't take too much, doesn't take too long, and it's the best way to proceed. So thank you very much for your kind attention.